So here we go again, spirochete diseases. These are always going to be a big problem because they're not just because they're on the boards, but because of their frequency as part of human disease. And so we're going to focus more, well, we'll review some, we'll focus more on the immunological testing. So how do we diagnose these? So just a few reminders about spirochetes. These are they are technically gram-negative, but they're a little bit different because of the axial filaments that they have, which um, run around, they spiral around the outside of the bacteria. It's actually not fully on the outside, it's in what is called the periplasmic space between the cell wall and the cell membrane, and they wind around, and because of the way they wind, they cause the organism to be helical in shape. And that gives them, it is a flagella, it does allow movement, but it doesn't stick out from the organism like the traditional flagella that you think of. And so you end up with a corkscrew movement. There's a lot of different, well, there's several different diseases caused by spirochetes, and you've heard of them before, but they all do share some similar characteristics. You end up with phased stages to the diseases. So generally speaking, they'll start out with a local infection where the organism has penetrated the immune system, followed by dissemination. Almost all have a latent stage, and that can be variable from just a few days or weeks to months or years. And then they all also do have the ability to cause cardiac and or central nervous system involvement. In all of these cases, serology is going to be the key to diagnosis, and that's mainly because culture of these organisms is not practical. It is possible. There are special medias that are available, and they do require specialized microaerophilic environments. And while those are possible, they make culture impractical and difficult. And so you would end up losing a lot of organisms in the turnaround. So serology has been much more useful in diagnosing these spirochete diseases. So of course the classic spirochete disease is syphilis, and you still have to learn it because there's not a lot left, not a lot of reduction in the actual incidence of syphilis. It still is a major problem. Although, interestingly, there is no natural reservoir in the environment. It actually, this organism, Treponema pallidum, needs to multiply in a living host. Okay, so this is not something, you don't get this from swimming in bad water or anything like that. Okay, I used to joke with my high school students. The only way you get this from swimming is if you're swimming naked with somebody else and having sex with them in the water. That's it. So this is very specific. You have to get it from a living host. There are subspecies, and we've talked about them in other classes. You have Pertenue, which causes yaws. You have endemicum, which causes the non-venereal endemic syphilis. And you have Caritium, which causes pinta. And those slightly different subspecies, so they're still pallidum, but they have some certain characteristics that are a little bit different. The organism itself, pretty small. It can be 6 to 20 millimeters long, so they can get pretty long with only 0.1 to 0.2 millimeters in width. That includes it's kind of like a wavelength, so from edge to, so from I don't know, peak to trough, I guess, if you're measuring across. And you also have to take note of the number of coils. We count the coils for each one. These pallidum will have anywhere between 6 and 14 coils if you're using dark field to diagnose this. Remember, the key thing for classifying, identifying syphilis are the treponemal rare outer membrane proteins, or TROMPs. These are part of what we can serologically trace these outbreaks to. Okay, and there's not a lot. The reason it's called a rare outer membrane protein isn't because the protein is rare, but that its expression on the outer membrane is rare. That makes this unique in the sense it's a plus and a minus. So yes, it's one of the few outer membrane proteins, and it is unique to syphilis. But because it's rare, it's not going to make it a very sensitive test if we test just for the TROMPs. So we can use the TROMPs as a way to classify a particular outbreak, serologically type a particular outbreak. But as far as a good screen, it's not really the best because it's a rare protein, so it's harder to interact with on in a serological test. In addition, that rareness of that outer membrane protein, since it's in any infection, it actually won't have that many copies in any one infection. Your immune system doesn't respond as quickly to it as something like an LPS, where there's several million copies on the outside of these, present in any single, or trillions, in any single infection. This organism is pretty easily destroyed by heat or cold and drying. This has to be, again, you don't get this from the environment. This has to be from direct contact. Doesn't last in the environment. Sexual transmission is the primary method of transmission. However, we do know that there is vertical transmission as well. So mother to daughter, as well as parenteral, which is needle exposure. So I'm a drug addict. I use it. I give my needle, I use half a dose in me, and I give my best friend another dose that can transmit the bacterium as well. Now, the stages of the disease, again, we're just going to fly kind of through this quickly. We know that the initial lesion is called a canker, and this will occur between 10 and 90 days after the infection, with about 21 days being the average. The key thing about this canker is that it is a painless lesion. This is one of the things that helps physicians to diagnose it because it is a painless lesion. However, it is also one of the things that helps in the spread of the infection, since most people who have painful lesions, like those lesions associated with herpes, do not, take part in sexual activity that would then cause it to spread within the community. A painless lesion is never noticed. It's not noticed by its host, and so therefore it can easily be spread. Now, this can heal spontaneously. It's not going to last forever, and it'll usually go away within 6 weeks on the outside. Okay, and that will lead to a secondary stage. It doesn't necessarily immediately lead, but you'll see a secondary stage following that, which is when you have systemic dissemination. You want to be able to catch the this infection within that primary or secondary phase, if possible. If you are unable to catch it, now that can last. Remember, the primary stage is somewhere between 10 days and 3 months, and then the secondary stage is anywhere from 6 weeks to about 6 months later. So you have about half a year to catch this. And there will be symptoms. Now, the canker is certainly a symptom, but if it's internal, obviously you wouldn't see it and it doesn't hurt. The secondary stage, however, you do have symptoms. Your patient will probably have a fever. They'll have some, flu-like symptoms in essence. So these are things that hopefully will cause the patient to seek medical attention and potentially will catch the infection early on. This secondary stage can start right away after the initial stage or the initial lesion, or it can really, you might not see it for a month, 2 months after that primary canker disappears. The infection will remain local until the secondary stage commences. It can also start immediately, even when the canker is still there. So we have quite a bit of flexibility. This organism can do pretty much whatever it wants as far as that goes. In that secondary phase, again, you'll have these sort of nondescript, they'll have lymph node enlargement, a fever, they'll feel run down. The key thing that they're definitely that would definitely point to syphilis is the membrane rash. So they get a rash on their skin and on their mucous membrane, and the classic sign is on the palms of the hand and the soles of the feet. That's the classic. Okay, you got to be thinking syphilis at that point. You also may see some neurological signs, although it doesn't necessarily mean that you're already into tertiary syphilis, but it's not obviously a good thing for certain neurological signs to start in the secondary phase. Following the secondary phase, we enter what's called a latent stage. In the latent stage, there's no clinical symptoms, so the rashes have, faded and the canker is gone, fever and all that stuff. You're feeling fine again. And so there's no real clinical symptomology to go along with the latent phase, but the patient still does have the organism within them, the living organism within them. However, in the latent phase, it is generally considered to be a non-infectious stage. Yes, the latent phase can be broken down further into early latent and late latent, but that's just really a matter of, how long does it last? Is it less than a year, more than a year? That's all that means. They are considered to be non-infectious with one exception, and that's if the patient is pregnant. A pregnant woman can pass on syphilis to her unborn child in any stage of the illness, initial primary through tertiary. Okay. But in the rest of, sexually, she's not going to pass it on, only to her child. It is with the end of the latent stage where we see the tertiary stage. Now, there's going to be some overlap here where symptoms are beginning to develop and you might not be aware of them yet. Okay, so the tertiary phase, if you are untreated in this latent phase, about 1/3 of all patients will move on to the tertiary stage. So 2/3 won't. They'll just stay latent for the rest of their life. And remember, this latent stage can last, years after the secondary stage is completed. This tertiary stage will develop in one of, hopefully just one, of 3 forms. You have the gummatous, where the patient develops these hyperplasias or these growths. They are painless growths, but they can get quite large, and you have a mechanical issue where they can interfere with blood flow, organ function, wherever they develop. Then you have cardiovascular syphilis, and you have in cardiovascular syphilis, generally what we see is the ascending aorta, is usually damaged. What happens is you have elastic tissue between the various segments of the aortic arch, and that it's not really the aortic arch itself that gets damaged, but the tissue that keeps it in place. And so now every time your heart beats, your aorta is moving, and it can lead to damage to the vascular tissue, which can result in an aortic aneurysm, worst kind of aneurysm there is. It can also lead to things like thickening of the valve leaflets, which will result in regurgitation. It can also result in narrowing of the ostia, resulting in angina. So there's several areas, several tissues in and around the heart that can be affected. And then finally, we have neurosyphilis, which is probably the most common complication, in particular in our HIV population. In neurosyphilis, we know that the organism has entered the spinal column, and the most common thing that we see is called tubus dorsalis, which is a degeneration of the lower spinal cord. The patient is going to they're going to have general weakness and even potentially a partial loss of voluntary movement. And they're also going to develop a chronic and progressive dementia, which I think is probably the classic thing associated with syphilis, that most historically what was most associated with syphilis. Now, none of these, once it gets to tertiary phase, we're not going to be able to reverse any of the damage that's caused, but luckily, because we can identify and treat syphilis in the 3 preceding phases, we have been able to stave off tertiary syphilis in most patients who become infected. It really is only that small group of patients who are really exceptionally stubborn and refuse treatment where tertiary syphilis continues and develops, or those patients where they don't have access to care. So those, you have access to care in this country, but not in every country. So you have, I guess, 2 groups, right? No access to care, or extreme stubbornness. The phases are all treated, successfully treated with penicillin or some iteration thereof. Penicillin, although depending on which phase you're in, which stage you're in, you might use a different formulation of penicillin, okay? But it really is, it's still penicillin. That's what we're using. And the detection has really come early on because of serology. So it is serology that really helps us to identify all of these different phases. And I'd like to point out, you've seen this this little cartoon before, or this chart before, but which test results do we use to identify the various stages? So in the primary phase, or the initial lesion, the canker, you're only going to have 3 tests that are available to you. This is only in the first 3 months, so your antibody tests, those wouldn't likely be positive yet. However, you can do dark field microscopy, right? That obviously could be positive. Very seldom used because it does require higher level training. You can also use, which is what we do use, the RPR and the VDRL. Now, you do have a chance that those will be negative. You'll note that it's not necessarily a 100% positive test. They do require some antibody levels. So it is possible, if you test too quickly, that you could miss a positive. And that's why, one of the reasons why you see that this arrow is not at the beginning of this line, okay? At this point, with the primary canker, your clinical signs and symptoms are very important, okay? You want to be able to find the canker. If they can find it, they've got a diagnosis. And the secondary stage, when the patient has those generalized flu-like symptoms and or the rash, remember that rash is really clinically characteristic. By that time, you should have at least for the RPR and the VDRL, you should have at least some antibody results. So those things you would likely see in the secondary, disease. And this would also take you through the latent. Okay, so this would include the secondary eruptions and periods of latency. However, once you go pretty far down the road past latency and you developed tertiary disease, your RPR and your VDRL frequently drop off. So they're not as reliable when you're trying to diagnose the tertiary disease. One little caveat I want to put in here for this with the VDRL. The VDRL technically can be run on both serum and CSF. Okay, if you are trying to diagnose neurosyphilis, the VDRL is the place where you're going to start. Yes, it does test for a non-treponemal antigen. However, it is specifically and very well designed for CSF. So this will directly screen the CSF itself. Is it 100%? No, it's because it's non-treponemal, it can't be. So all of your other antibody tests come into play. So why do I mention this? Because remember what I said, our largest population with tertiary disease, in particular neurosyphilis, is with our HIV patients. HIV patients are immunocompromised. One of the things that takes a hit are their antibodies. Their antibodies can drop off. They might not produce them anymore, depending on which way their immune system went. The VDRL sometimes becomes our only choice to test these patients. Okay, and even then we might not be 100% on the money. So these are just some examples. You've seen them before. Okay, just to remind you, here's the rash, palms of your hands and soles of your feet. So now every time you see a little polka dot, you're going to freak out. But this is very specific, and it will go along with other symptoms. Okay, the cardiovascular syphilis, this is just showing some changes to the valves where the valves they're weakening, right? So there's some atrophy to the valves and you end up with regurgitation. This, remember, you get leaking through the valves when they're supposed to be closed. Okay, so this is not good for the way your heart could feel. This is, we don't see this as often. I have seen it in some patients before, but this is a bust of a gummatous syphilis patient. So you can see these large growths that have formed. You can see there's one behind this poor fellow's eye, and they're all over his head and his nose. Some of them, they will come and go through the phases. You can see that they're grossly disfiguring. And unfortunately, one of the things, you know, in literature, we talk about ancient literature, or at least this is one of my things, you can see where syphilis, which is an old disease, could you see where why somebody, you know, let's talk about, you know, prehistory or ancient history, why they might look at this person and see this person as being, you know, these are growing and shrinking over time. And this person would be probably labeled as being possessed by the devil, because they might also at the same time have some neurosyphilis lesions in their brain, which would cause some serious dementia. Okay. Congenital syphilis, this is one of the hard ones to diagnose without all the signs and symptoms. So because of our serological testing, we have been able to really identify these babies very early on. In some cases even before they're born, because we could test their parents. Okay, so pardon me, some of these are cases where some of these signs come from cases where the baby is born to a mom who was infected, and the highest risk would be in the second or the third trimester. And so if a woman participates in prenatal care, we would be able to hopefully find this. But some of the signs that you'll see for these poor little kids, the first one might be what's called necrotizing phonistis, which is it's an inflammation of the umbilical cord. That might be the first thing that the doctor notes. They also might have these rashes. It's a rash that's associated. See the hands? You can see it here, and you can see it up here. Remember, this occurs to the parent as well, the mother. Palms of the hands, soles of the feet. Those are the most common places, but they're not the only places. You can see that this baby has some obvious signs going on in the rest of its body. They'll have lymphadenopathy and hepatosplenomegaly. They'll likely be jaundice. A lot of babies are jaundiced, so that doesn't help very much. They'll likely have anemia. They'll have painful limbs and bone abnormalities, and that includes things like, this is saber shins, saddle nose here. This probably wouldn't be noted very early on, but the saber shins, this would be a baby that won't stop screaming. And to touch its limbs, the baby would start screaming. They'd do an X-ray, and they could see these. You can see these bends to the Limbs, and obviously babies aren't born with teeth, and so once their teeth come in, you note Hutchinson teeth, they're bowed up and they look like they're split in the middle. Okay. In all the babies that are born, um, if you're born with syphilis, there's a much higher rate of developing neurosyphilis in those babies. So about 60% of infants born with syphilis develop neurosyphilis as infants. Okay, so it's not a case of they don't have the same kind of 10 to 30 years that an adult has. They don't have the same blood-brain barrier. They don't have the same immune system. So there's the chances of it remaining latent are very slim. Okay, so very high risk for infants born with this particular organism. Now, what are our defenses? Pardon me. What are our defenses against this particular organism? Well, obviously intact skin is our first one. When you're talking about the mechanism of transmission, obviously intact skin, you're good. It's when there's a break in the skin that this organism, which remember is helical, look my terrible drawing, it will be able to, in a screw-like fashion, make its way through the skin itself. Once it penetrates into the skin, your T cells and your macrophages are the key players in the immune response. Okay, you have both. If we were to examine a primary lesion, a canker, we would find both CD4 and CD8 positive cells present in those lesions. There'll also be macrophages, and those macrophages are able to phagocytize both the organism as well as the damaged tissues that are generated by the infection in order to heal that primary lesion. Yes, there are antibodies produced, but remember, a coating of the treponemes, these antibodies would be directed against those the TROMPs, the treponema rare outer membrane proteins. And this looks like, oh wow, if I have this many antibodies, that's great. They would be able to, my immune system would recognize this and, pardon me, eliminate it. But because there's so few of those rare outer membrane proteins, we don't get good coating of the organism, and you don't end up, it doesn't necessarily mean you'll be able to remove that organism from circulation. Also, the pallidum is also capable of coating itself in other host proteins, non-antibody proteins, in order to continue hiding itself from the immune system. Okay. Eventually, the antibodies will bind to the TROMPs, and once that's done, complement can be activated. Complement will be necessary in order to kill this bug directly, but it just takes longer because there's so few out membrane proteins to target. Now, how do we find it? Like I said before, when we're talking about the first phase, direct detection is probably it's still a good method. Obviously, we can demonstrate the actual organism in any kind of exudate from the skin lesion. So if you don't want the scab, okay? So the canker has a hard, crusty surface. And this is objectionable because while the canker doesn't hurt, if I inject it and suck out the liquid, that would hurt. So we actually need the fluid beneath the canker, send that to the lab, and we can look directly at that fluid and see if we can see organisms within it. Now, it's very important to recognize that that fluid would be contagious. So a technologist must be careful when they are working with that fluid, okay? So that's what we mean by exudate of the skin lesion. So you don't want the scab itself. They're actually going to put a needle below the scab or remove the scab and extract some of the liquid that's below the actual canker, which is not a pretty process. And again, specimen quality is essential. If these die, you're not going to see them moving. If they don't move, they don't throw the light up into the lens that you can see from. Okay, dead treponema, very difficult to see. We do have an answer to that in a sense with a fluorescent antibody stain. We can do that. It is sensitive, it is highly specific, and you can do it with either direct or indirect conjugate staining, okay? And in this case, we don't have to worry about whether or not that specimen is live. And so that's the key thing. If dark field microscopy, if the organism is no longer live, we're really not going to see it. It's going to really limit how well we can see this thing. But with the fluorescent antibody testing, it can be dead. So that means you could fix it, which would reduce the risk of contamination, not contamination, of transmission within the lab, okay? Our big problem with the fluorescent antibody staining is the cross-reactivity within the species, between species and subspecies. So the fluorescent antibody that we have that's directed against pallidum will probably cross-react with some other species that are a little bit less related. Okay. However, what's the normal number of spirochetes you should have in your body? None. Okay. It's just that we don't want to misdiagnose it. If it's really not pallidum and it's really a Borrelia or something like that, we don't want to make that mistake. Now, direct testing is not as frequent because collection of the specimen is it's rather painful and cumbersome. So serological testing is certainly something that's more common. And especially if you don't have an active lesion. If you can't see the lesion, if it's an internal lesion, patient's not aware of the lesion, we can use serological testing for quick screens. They're relatively cheap and easy to do. So we can screen people at given points in their life. Screen everybody that, shows up for the military. Screen everybody that wants to get married, which is still done in some states. Screen everybody that has a baby. These are all times when we can screen you at regular points in your life to make sure that we reduce the overall spread of this disease. All of this serological testing will be classified as either a treponemal or a non-treponemal test depending on the reactivity of the antibody that you're using. Okay, those non-treponemal tests, the VDRL, the flocculation, the RPR, those react to, well, flocculation has a couple of ways, but the VDRL and the RPR, those react to cardiolipin antigen. So what you're looking for is actually an anti-cardiolipin antigen antibody. Okay, this is the cardiolipin is actually it's lipid material. That's its name. That is released from damaged cells. So this bacteria is moving through the tissues, damaging cells, and this cardiolipin is released. Your immune response is against the cardiolipin, which is, it won't be specific to a treponemal infection, but it is very highly suggestive. Okay, so yes, you can get a positive RPR or VDRL with a non-syphilis situation going on. And for that reason, all non-treponemal testing must be backed up with a treponemal test in order to verify the results. Okay, so just to give you an example, pregnancy, even though it's not considered an infectious stage, it actually does have inflammation occurring with it. And in particular during the production of the placenta, when you have placental tissues and maternal tissues meeting up, interacting, they're both foreign, each one finds the other foreign. And so you have an immune tug of war between the two of them. That will release, that'll damage tissues. The placenta is trying to dig into and set roots, as it were, in the maternal tissue, and the maternal tissue is trying to prevent the placental tissue from moving into its territory, as it were. So this will cause the destruction of some tissues. That releases cardiolipin. So you do get cardiolipin antibodies spike a bit, or they rise a bit, I should say, not spike, but they rise a bit during pregnancy. But those would almost always be very low titer situations. For syphilis, where the tissue destruction is caused by the bacterium, you end up with higher titer levels of RPR being produced. Another name for the anti-cardiolipin antibody is reagent, and that's actually the reagent that we use. The reagent is made of cardiolipin, cholesterol, lecithin. Those are all put together in this, and charcoal, all put together in the RPR reagent. VDRL uses the same reagent, but without the charcoal, okay? And generally speaking, in about 1 to 4 weeks after that primary canker appears, you will start to see RPR and or VDRL levels increase. Now, flocculation it's a test that's really not done anymore, but it is a non-treponemal test. There is a non-treponemal version of it that allows the patient antibody, serum from the patient, to interact with cardiolipin antigen, which is basically RPR reagent minus the charcoal. And this will occur over a narrow range of concentration, and you get a precipitate that forms where the antibody and the antigen are forming a precipitate in the test substrate. The problem with flocculation is because you have to see this precipitate directly, and it's very difficult to do. Now you'll titer it out so that you can get it over a range of concentrations, and you'll end up with pretty high sensitivity to prozone. Okay, remember what prozone is. And you see these very fine particles in your suspension that you're supposed to be able to identify. Okay, so you have to look at each of your, now flocculation you would have to run at a dilution in order to read the entire thing. RPR is a little bit different. RPR takes the same reagent and adds charcoal to make it more visible. And that way you can see it more easily and makes it less likely that you'll miss a positive whether it's because of prozone or not. However, we still have to consider prozone, and so we do run it. We can run it at a dilution in order. We always run a titer anyway, so that we would see any high positives. VDRL is a test that was designed by the Venereal Disease Research Laboratories at VDRL. It has both a qualitative and a quantitative slide. It is a flocculation test, and it runs both a serum and a CS. Well, it has a modification for a CS. You can run either one for this. Not that you run each one on every patient, but you can run a serum test. And they also have this modified version that includes like a heating step and all that stuff that is for a CSF run for that kind of sample. VDRL is still used for CSF specimens because you can't run CSF using an RPR. But VDRL is still very manual test. You still have to prepare the antigen daily. It has there is a certain level of error because you're preparing it daily, and it is obviously very short lived, very short shelf life. Okay, there's specific tools that we use for both the VDR and the RPR. Is I don't know if you've run any of them in the laboratory yet, but there's a specialized syringe needle that we use. It has to be able to deliver 60 drops per milliliter in order that we verify that the amount of reagent that we're delivering to our test system, even if it's just a card, is exactly the same for each patient. It also has to be tested within a very specific window of temperatures. You can't let your room get too hot or too cold. And then it really is pretty quick. So you add for the RPR, for the VDRL, it's more preparation that takes so much more time, and it is a flocculation, so it's not as easy to read. You read it with a frequently with some form of magnification. But RPR with the charcoal added, it's really easy. You take a drop of your reagent through that Hamilton syringe, a drop of your 50 microliters in a drop, 50 microliters of your patient serum. You spread it out to fill out the whole card, and then you rotate it on your serological rotator for 8 minutes. It's not very hard. And you read it. If it's got no precipitate formed, you're good to go. It's negative. Okay. So you're looking for, it's really called flocculation, right? These really small clumps. The VDRL does have to be read microscopically, but the RPR does not because of the addition of the charcoal. Okay. And then if you end up with a titer, if you end up with a positive, you perform a titer, a doubling dilution titer, and you report the positive screen and the titer at which the last level that it was positive at. Okay, so if the last level was 1 to 32 and the 64 is negative, then your titer is 1 to 32 or 32. Pardon me. Okay, so once you have a positive non-treponemal test, then you send it for the treponemal test as a verification. So you're going to report the positive screen and the titer, then you're going to send the sample for verification. You're going to do all three. But you can report the RPR or the VDRL even before you send it for the test. The most common one sent that we do today is, well, actually, it might be being taken over by ELISA, but basically they're the same thing. It's an FTA antibody, which uses an antibody directed against the pallidum or specific treponemal antigens. The FTA, the classic one that we're used to, is an indirect fluorescent antibody test, where they heat and activate the serum, and the main reason for that is to eliminate complement. Whenever you hear heat and activate the serum, you're thinking, oh, I got to get rid of the complement that's in that serum because I don't want it to interfere with my test. In particular, this would be important if you're doing a hemagglutinated. So if you're using a red cell reagent that has treponemal antibodies absorbed onto them, you definitely don't want complement in that picture. So you would have to heat and activate it for that purpose. So you heat and activate the serum, and you allow it to react with the antibodies. With the antigens that are present. In some cases, they will be absorbed onto a red cell. In some cases, they will be fixed to a slide. And now we also have ELISA, where they're at the bottom of a microtiter plate or something like that. The antigens come from a very specific strain of non-pathogenic treponemes called the Reiter strain, and that has shown reduced cross-reactivity with treponemes other than pallidum. So the non-slide tests use the Reiter strain. Slide tests, so where they're fixed to a slide, those usually use the Nichols strain. Okay, just to be confusing to you. And then you follow the rest of the procedures for any kind of ELISA. Allow your patient's serum to react with your test, platform, whatever it is. So you add your serum, wait, let them react. Wash, add your antibody, wait, let them react, wash. And then in some cases, in some test methods, you'll need a conjugate because that initial, it's an indirect test. In other cases, you'll be able to read it directly from that. You still have to wash to remove the unbound antibodies, okay? And we grade our reactions with this. Anything that's a 2 plus, 2 plus or better is considered reactive. 1 plus is considered minimally reactive, and in many test platforms and test kits, that would require being repeated with another specimen in about 2 weeks. And what it's assumed is that might be a very weak or very early antibody response. So you can get an equivocal result. Equivocal results should be followed up on top of that, okay? This one, the FTA, the treponema tests do require a certain amount of experience to read. They are very sensitive, and they can be specific, but they are time consuming, and we have to make sure that we don't overread them. Again, we do have hemagglutination tests, which has been called the TPHA, or treponema pallidum hemagglutination test. We don't use them in the United States anymore, but the same kind of reagents have been transferred to particles. Okay, so they've taken the same, remember that was the Rider strain, they've taken the same strain antigens and they've moved them to particles instead of red cells. And what you do with that is you get the same kind of specificity and you eliminate that possibility of complement causing a false positive result. Okay. They've used a whole bunch of different particles. You know, I mean, every manufacturer, they could decide on what kind of particle they want. They've added it to magnetic particles and instrument and let the instrument read it. They've used gelatin particles, and that allows you so that then you can see the gelatin, right? It comes together. They've done it in a microtiter plate. They've done a whole bunch of different test methods. And, you know, if you want to start your own lab, go ahead. You can create one of your own. There is no thought that syphilis is anywhere near being eliminated worldwide, okay? So why do we need both a treponemal and a non-treponemal? Okay, hopefully what you heard between the two, treponemal tests, higher level of experience, more difficult to read, and shorter life. Well, actually, some of them are getting pretty good as far as their shelf life. What about that RPR, which is our generic screening test? Cheap, easy. We love that one. 8 minutes and you're done. Okay, so screens should be cheap. They should be easy, and they can give you a pretty good qualitative result. But they're not specific, so they have to be backed up. And it allows you to reduce the total number of tests that you end up sending for the FTA or for any of the other tested. Now the treponemal test, one last thing to point out here. The treponemal tests actually, if we look at them, they'll probably be reactive before the non-treponemal tests. If we were able to test you from day one here. Your non-treponemal test, and if you look at this here, you can see here's your time of infection. So this is just giving you the symptoms here. And you can see that there's a slightly, see the FTA, the blue line, is slightly earlier than the dotted line, which is your VDRL RPR line. Those are your non-treponemal lines. So you can see they come up slightly before. It's not a lot, but it is before, and they'll generally stay positive longer. So why? The other reason why in addition to the cheapness of it, this treponema, non-treponema one, if you have it treated, look how far down it drops. Okay, this drops down really far. But syphilis is not one of those situations where your immunity to syphilis will prevent another infection in you. So if your second infection comes here, your FTA ABS is now no longer, this is all the way up here for the rest of your life, right? Stays this way. How do I know that you got another infection? I can use your VDRL and your RPR to see that, okay? So these are just pictures, just so you can see. You saw this before. You did an RPR in class. Pretty simple card test. We love card tests, right? They're so simple. Here's your flocculation. This is a glass micro well plate. It does have a card version as well. Glass is going to be easier to read overall, believe it or not. And you can see these you have non-reactive, which looks very grainy, and then it starts to get progressively more grainy. And the reason this is it doesn't really help to look at this picture, because you will have to read this with a this glass light with a some kind of magnification. Okay, you can't just look at it with your eyes. Nobody's that good. Okay, here's your FTA ABS. So this is a fixed nickel strain on a glass slide. The serum was allowed to interact with it. The patient had antibodies that bound to the nickel slide. Those were loose. Serum was washed away. You added your conjugate, which caused it to fluoresce. Okay. And these are the agglutination tests that we're looking at here, where we're relying on the complement to interact with the red cell, the antibody that does bind, and it causes hemolysis, no pellet. Okay, hemolysis occurs. Okay, we don't use this anymore because patients have complement anyway that might bind for any number of reasons. And also, red cells don't have a very long shelf life. Okay, so we don't use these in the US anymore, but the same materials, same reagents have been converted, and they use different particles in order to get similar results. Even newer tests. The EIA is again also present. They have the reason we really like enzyme immunoassays is because they can be pretty easily put on an instrument. Okay, we like to put things on instruments. So we do get pretty good sensitivity, but unfortunately we have a higher rate of false positives. Part of it has to do with the sensitivity. Remember, there's a lot of reasons why you might have a positive result. It depends on what you're using. Are you talking about an EIA for a non-treponemal antibody? If that's what you're looking for, then yes, it's very sensitive, but there are other things that can cause non-treponemal antibodies. Okay, so and as well, the sensitivity will decrease as the disease progresses, which we already know about non-treponemal antibodies. Because of these methods, this is not taken over the industry. The RPR is still, people are quite happy with that. Some of the other benefits of EIA is that we are able to differentiate IgG from IgM. And IgM is important in diagnosing, in particular, congenital syphilis, but also new infections. So a patient who we know has a history of syphilis, if we note an increase in their IgM titer, then that would be a pretty good sign that they, whoops, got it again. Okay, these are continuing to improve. Again, those card tests still require a tech to read them subjectively, right? If you're reading it, it is by definition, it has a subjective element to it. And so we want to increase the rate of objectivity, which means we want to put a machine behind that read as much as possible. And that will hopefully, if we keep improving these EIAs, we can start putting them on an automated platform. Okay, and if we continue to improve them, it'll allow us to increase not only the rates of diagnosis, because syphilis isn't going away anytime soon, but also we could potentially improve our staging of the disease, which isn't always the easiest part of syphilis. When you're differentiating in between the latent, the secondary, the latent, and the tertiary phases, it can be pretty tough. Okay, so we have a generalized way to do that, but there's a lot of overlap that makes it difficult to be sure. Note this little flow chart here. If you use a treponemal EIA test, specifically an EIA test, If you have a non-reactive result, you're done. It is sensitive enough that you can say, okay, the patient's non-reactive. You still, once you have a treponemal EIA, you're going to follow that up with the VDRL or the RPR, depending on which one you're testing. And depending on what you get, you're going to, again, follow down a different, if you have a non-reactive, obviously if it's reactive, you're going to say, well, probably. If it's reactive here and it's reactive here, my patient has syphilis. If it's reactive with the EIA but non-reactive with the RPR, say, this might be a very recent infection or a false positive. So probably you're going to perform a second treponemal test. And then you end up, meaning if you did an RPR, maybe you'll do a VDRL. If you did an RPR, maybe you'll back it up with an FTA ABS, something like that. Okay, so it does require extra steps in the testing, something else that makes it unattractive to hospital lab managers. In addition to EIA, of course, we have molecular testing. We have PCR. PCR is basically going to be used when we're talking about tissue testing. So we have a tissue that we suspect the organism is in. We can use PCR where we don't have a platform for a solid phase tissue in any other situation. They basically, what they do is they amplify bacterial DNA and they perform southern blot to separate it. Once that DNA is amplified and separated, you stain it with a probe for the specific DNA sequence that you are looking for. So if it's pallidum, that's what you're going to stain for. Okay, obviously this is extremely sensitive, and this is one of those things that they're thinking about using for CSF. And the reason is we have VDRL to run as a non-treponema test for CSF. But once we go to treponemal tests, those are antibody tests. Antibody levels in CSF are very, 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 very low, and PCR can detect as low as a single organism in an entire sample. Okay, let's presume a sample is 1 mil, which is what they usually ask for. So 1 organism per mil, that's pretty good. Now other fluids is a little bit less sensitive. You can see that with serum, with all the other antigens and proteins that are around, the sensitivity decreases to 70%, which would not be considered suitable. Okay, so some of the other tests are probably sufficient for that. But when you're talking about neurosyphilis, a PCR test is quite appropriate. Okay, so congenital syphilis. This one, I put this here for you. This is from, I forget which hospital. See, I should write these things down. This is from a single hospital and the testing flow that they would use at that hospital. I don't know that your hospital has a flow chart for this because you don't have an OB department specifically, but that doesn't mean that you wouldn't have newborn infants with potentially diagnosed with cancer. And doesn't mean that you wouldn't necessarily need this. So the reactive material, if you have you start with a reactive maternal RPR VDRL, and they take you where to go down the chain before you get to treatment of the patient. It is not 100% of the time. Just because your mom is reactive doesn't mean that the baby is definitely going to be infected. Some babies are definitely lucky in that they don't get infected. So, but once you have a reactive maternal treponema test, we have to consider testing. You have to consider testing the baby as an important step of the perinatal care. If it's non-reactive, there'll probably be at least some treatment to prevent seroconversion. Remember, this baby doesn't have an immune system, so you're not going to leave the baby completely without any treatment, but maybe at least some treatment. And you can see down here the treatments that they're talking about. Now, you're not so worried about individual treatments. You're worried about, okay, how do I go on with the baby? If the RPR and the VDRL is positive, is reactive, Then we start to look at the titers. How bad is the titer? Am I looking at an antibody level? This is the important part. Am I looking at the mom's antibody level, or is this the infant's own antibody level? See the difference? If it's less than 4 times the maternal RPR-VDRL, it might be the mom's antibody level that I'm testing. If it's more than 4 times, at least 4 times, right, 4 times or more, then it probably is the baby's, in which case I need to really look very closely and consider much more aggressive treatments. This is the 3rd level of treatment for this particular infant. And the reason is this baby's a very high risk for neurosyphilis. Okay, if really what I'm looking at is likely a maternal antibody level, well, then I've got to consider a few other things. Okay, the infant's exam is normal. It looks like we either might not need treatment or we might only need a limited treatment. Okay, this is the key part that I want you to note about this. You have to compare the titers from the mom and the baby, because of course the baby doesn't have, we don't consider a baby to have a functioning immune system. They do have some immune system, however. So if I have the same or only a little bit higher antibody result compared to the mom, then it might just be the mom's antibodies that I'm seeing. However, if I've got a very robust antibody level in that baby, then I'm considering that this baby is likely producing its own immune response against this, and there's a problem here. Okay, so note that about congenital syphilis. With neurosyphilis, again, another difficult one to diagnose. Definitive diagnosis requires 1 or 2, so 1 or 2 plus 3. You have to have 3. Reactive VDRL-CSF has to be done. Okay, so identification, so this one here, the PCR or microscopic examination, this has not been widely enough studied to be able to be used as diagnosis alone. You must still do that VDRL. I suspect as this gets more widespread use that this will become the gold standard, but at this point VDRL CSF is still considered gold standard. Okay, and then that's for a definitive diagnosis. Presumptive diagnosis, reactive serum treponemal test, so FTA-ABS, okay, plus the clinical signs, and an elevated CSF protein or leukocyte count in the absence of other, so meaning you've ruled out everything else for this change in the CSF, so I'm going to think that it's probably neurosyphilis, okay. In these cases, 1 and 2, and then maybe 3 is there, okay? So to get a presumptive diagnosis, you don't necessarily need to have, because you're going to start treatment, okay, is the key thing there. Remember, damage to the nervous system, you don't get that back, it's gone. So starting treatment earlier rather than later, that's important. Okay, now we switch to Lyme's disease, your other favorite spirochete. This one was first described in 1975, and it was actually first recognized by some moms in the area of Old Lyme, Connecticut, who noticed that there were an awful lot of kids with arthritis in this area. And they actually, these 2 moms, actually approached the health department and said, we think that there's something going on here. And it was from the actions of those moms that a study was commence, and the first diagnosis was based solely on the epidemiological features. And it wasn't until 1982 that they suggested an arthropod vector. So you got 75 is when it was first recognized by the moms. That's when they first recognized it. And it wasn't until well, I shouldn't say in 82. They pretty soon after they were thinking there was an arthropod vector. Why? Because they noticed that it was being diagnosed, and that's where this chart is here. Look at the months where it peaked. Any epidemiologist knows when the bugs are active, and they knew this is when ticks are active. So they suspected that this might be due to an arthropod vector. But it wasn't until 1982 that Borrelia burgdorferi was isolated and identified, named after Willy Burgdorfer, he actually was the author of the original description. So he didn't identify the bug. He was the author of the original description of the syndrome. Okay. And then eventually they realized that this syndrome actually went well beyond just arthritis. It is a multi-system disorder, and it affects the skin, it affects the nervous system, heart, joints, all those. It can really go pretty far. Okay. Lyme's disease is now the most common vector-borne disease in the United States. Although if you look, you see that it has some pretty tight ranges, right? If you live in the Midwest, this is unlikely to be your problem. However, around the Great Lakes, the Michigan area, you have some problems, and also Northeast is really it. Okay, but it is still the most common in the United States. It does also exist in Europe, although there are several other species that are known to cause Lyme's disease. In our area of the world, the main reservoir host, meaning the main organism that can harbor the bug without really getting sick, is the white-footed mouse. And this is, but it is present in other rodents. It's present in the dusky-footed wood rat in California and in Oregon. There's a lizard on the west coast that's called the western fence lizard. They're actually trying to get this lizard spread out. If the organism goes into this lizard, the blood is bactericidal for that and all that stuff. They have all these crazy things that they're trying to follow. I'm not really sure what we do about all of, pardon me, about all of these different organisms that can harbor it. The reality is you got to keep the ticks away from you. The mouse is not biting you. Okay, it can go through a deer. The deer is not biting you. The problem is the tick is biting you. So you've got to keep yourself away from the tick. Plus the tick carries other things too, so you should stay away from it anyway. So in the tick itself that we worry about here in the Northeast is Ixodes scapularis. And in the Midwest and the West, it's called Ixodes pacificus. Hopefully that should be able to remember. You'd be able to remember. The organism itself is a 2 to 25 millimeter long spirochete, and it's 0.2 to 0.5 millimeters in diameter, so it's a little bit narrower than pallidum, and it is loosely coiled, so less coils than pallidum. The life cycle of the vector, just a quick one here for you. This is a 2-year life cycle for the tick. We used to, when I was first in this and we were first diagnosing this, we used to get ticks in the laboratory all the time. People would pull the tick off of their kid and send it to the laboratory, or themselves and send it to the laboratory, and we would have to diagnose the tick, like speciate the tick, and also give a phase in the tick. And the thought was initially, and I remember we had to figure out, is it a nymph, is it a male, is it a female, is it Ixodes, what is it? The reality is we found Borrelia in a whole bunch of other ticks, so it doesn't really matter what the species is. We also did testing on the tick to see if it had Lyme in it. Again, who cares if the tick has Lyme? We want to find out if you have Lyme. Okay, if we see certain clinical symptoms, if the physician sees certain clinical symptoms, so we know you have a tick bite, you have a rash associated with that tick bite, they're going to start treatment, okay, which is doxycycline, I believe, for a month, which is no small feat. But basically, the life cycle of the tick is important. The tick is going to hatch from the egg, and note, the larval phase has only 6 legs. Okay, that's important. Got to be able to count to 6. And when the patients are pulling this off of them, they lose legs. So that's, you got to look for the attachment points. Now this larvae has to eat, so it eats on warm-blooded animals. Now there's no rule that it has to be a small one, so I would probably disagree with this little picture. The tick doesn't say, well, I'll pass up a deer and I'll only go for a small animal. It just goes for a warm-blooded animal. However, this animal, this tick, can't move as fast or as far, so it's more likely to get onto a small animal. Anyway, feeds off of a small animal, assuming this is the white-footed mouse. The white-footed mouse carries Borrelia burgdorferi, so it lives in the salivary glands in the gut of the larva. Over the fall and the winter, it becomes dormant, and it lives usually in the piles of leaves, you know, in the woods and stuff like that. So it finds a warmer area underneath all those leaves, and it just hangs out. So then, comes spring again. It comes out from the underneath all of its, you know, dead and dying leaves. It's very hungry now. Okay, and note, it's no longer a larvae. How cute! It's now 8-legged. It's an adult tick, and now it can feed on. It's not that it feeds again. It'll take a mouse. There's no picky here. It's looking for a warm-blooded organism. It can feed directly on you. Remember, it's already been infected. It's salivary glands, and so when it feeds on you, it sticks its head in. It sucks blood. For approximately 24 hours, they will be attached. Then when they leave, when they pull out of your skin, they will regurgitate, and their saliva will enter your body. That's the thought of the process. So you have a couple of things here. It can go up on your dog, and then your dog comes in and it snuggles under the blanket with you, and it can cuddle in and get to a place on you. One of the things, these ticks do produce a numbing agent that they can inject into the skin so you don't feel their bite. So you won't necessarily feel them bite. And then they go from your 8-legged nymph to a full stage adult. I guess this is kind of like a teenager here in the spring. But through the summer, it becomes a full-blooded adult. Again, it'll feed more through the summer, and it'll lay its eggs that last after the fall and winter. It'll lay its eggs. That'll come out the next spring. Okay, so more than you wanted to know about ticks. The key thing is, where do you come in contact with all these other organisms? The most common place is through your pets. So your pets go out, they rummage through the leaves, they chase the mice and the deer, and the ticks fall off, and then they can jump up and or walk up onto your animal. Your animal then brings them into the house. Or you love going out in nature and looking at everything, and so you walk through, you kick the leaves, and the tick is able to get onto you and create its own blood meal off of you. Okay, so the life cycle is important in the sense that the tick itself has 2 years, a 2-year life cycle before it starts another process. These eggs do not come out infected. It has to have a blood meal before it gets infected. Here's your bug itself. It's a little bit more loosely coiled than Treponema. It does still have it does still have antigens on its outer surface, but they're not tromps, obviously. It's not a treponemal antigen. Instead, it has OSPA and OSPF, which are outer membrane proteins. They're actually um, lipoproteins, and they're encoded by plasmids. Okay, so they're known as outer surface proteins. And these outer surface proteins are actually the part of the organism that allow it to attach to cells inside the host. The endoflagella or the periplasmic flagella, whichever you want to call them, these are these contain some proteins against which you show a very early response against, okay, your immune response. So we can find antibodies directed against these periplasmic flagellar antigens very early on in your infection. However, there's an awful lot of cross-reactivity. So this is one of the things that is a big problem with spirochete testing, is all the cross-reactivity, okay? Remember that these can be cultured. There's a specialized media called the Barber Stoner Kelly liquid medium, and we would incubate the specimen at 33 degrees. But it really is a cumbersome process, and the spirochete doesn't really live all that long, even in the tissues. So it's very hard to capture the bug. Like, what's the best place where you can presume that there's definitely a lot of bug? Well, you would look for that rash, right? The target rash that we would be associating with Lyme's disease. And it's true, if I were to take a biopsy of that particular, of the skin filled with there would be bugs all within that. Unfortunately, they don't live very long there. They have to progress to the next stage. Capturing the bug at that site becomes the problem. In addition, growth on a culture media can take up to 6 weeks. So it takes a very long process, a tedious and difficult process, not very helpful towards diagnosis overall. Just like well, not just like syphilis, but similar to syphilis, we have stages in this disease. It starts out with the localized rash, which is called erythema migrans. This is the clinical hallmark, right? Target rash. It's a localized infection at the site of the bite. However, it's followed by pretty early dissemination. This will happen pretty quickly in Lyme's disease, much more quickly than in syphilis usually. This can result in several things. Continued skin involvement, so you get multiple lesions, not because you had multiple bites, but because the bacteria has moved through your skin and is just creating these small little outbreaks of infection. Usually it'll go through the reticuloendothelial system. But it can also move to other organs, including the heart and the central nervous system. You can end up with, in dissemination, you can end up with something called AV block. If it goes to the heart, one of the parts of the heart that can be affected is the part that controls the electrical current within the heart. If that's affected by a lesion of Lyme's disease, this patient will certainly have problems, and it'll look like they'll probably need a pacemaker, because we don't want them to lose their electrical involvement. In addition, neurological involvement can result in facial palsy. These are not 100%, but these are the major risks that we can see with these kinds of dissemination. Then late dissemination is associated with the arthritis that those moms saw early on in the history of this particular organism, and then late neuroborreliosis. This is where you see significant neural changes, pain, lots of pain, headaches and things like that, changes in the back of the eye, the ability to, voluntary movement, things like that, as well as meningitis and encephalitis. When we look at the actual manifestations, the clinical manifestations, look at the percentage of each one. You can see meningitis, encephalitis, and the cardiac AV block issues Those are at the lower end, 1%. That's good, right? Those are pretty bad. However, radicular neuropathy, Bell's palsy, those now we're starting to creep up. Arthritis is probably second to the target. Arthritis is the most common finding, okay, with 1/3 of patients demonstrating arthritis. But the target is upwards of 2/3, more than 2/3 of the patients demonstrate that target rash if they're looking for it, okay? Now this was through 2010. I'm sure we would have new numbers and new percentages as our rate of identification has improved. Diagnosis is defined by the CDC. The way that we have to do it in this country is recommended by the CDC, which means that this is what your insurance company is going to pay for. Generally speaking, unlike syphilis, where if we look in that primary canker, we'll find. We can look for the spirochetes and find them using dark field. Dark field would work potentially, but it's very difficult to find viable organisms in a primary specimen because they don't live very long. So remember, you're not its natural host, as opposed to treponema where you are. Okay, so you're not this organism's natural host. So they don't live very long. In that case, dark field's not a good, it's possible, but it's not a good choice. And so serology really is a better methodology. Okay. So we CDC requests or recommends that we use the 2-stage or 2-tiered testing system for Lyme's disease. Your first test should be either an immunoassay or an IFA, which will demonstrate, it's a screen basically, where you test for an antibody present in the patient that is specific for a generalized Lyme antigen. And depending on the kit, it can be a different Lyme antigen for each kit, and each antigen will have a different level of specificity. C6 protein, which is one of the proteins that is present that is expressed on Borrelia, seems to show the highest level of sensitivity to date. They'll hopefully come up with newer ones. So we're getting pretty good results with C6. So we can do this with enzyme immunoassay. We can do this with immunofluorescent assay. Both of these can be automated, so that's good. Okay. If you get a positive or equivocal result with either of these test platforms, then it needs to be sent for Western blot. Okay. Now this here is saying if the signs or symptoms are either greater than or less than 30 days. Generally speaking, the physician won't send you for the test until at least 30 days after the identification of the bite symptoms. Okay. So, you know, if you get a bite today, you would go to the doctor so that you can start your drugs, but they wouldn't actually do the test for at least 30 days because we need time for that antibody result to build up. Previously, we would probably do an antibody test on you right away, but knowing the immune system as you do, that doesn't make a lot of sense. So a lot of times the doctors, they should anyway, wait. 6 weeks is usually the best time to wait, and then you can do a Western blot. Okay, they do not necessarily require that you do both IgG and IgM. However, remember, the lab doesn't really know if signs or symptoms are there, so generally we do both IgG and IgM. Western blot. In this case, what you're doing is you're testing the patient's serum against separated proteins from Borrelia, and you have to show reactivity with a certain pattern against those antigens in order to call it positive. And the reason for this very complicated test is that you have cross-reactivity. So we want to make sure that we aren't calling people positive when they're not positive at all. Okay. In addition, remember, of course, we have PCR. We can do Lyme PCR, and that would obviously, there's no normal amount of Lyme that you would have, but Lyme PCR is limited to fluids. We do Lyme PCR on CSF if we suspect neuroborreliosis, and we do Lyme PCR on synovial fluids if we suspect Lyme arthritis. We could do it on a pericardial fluid or something like that as well, or tissue, but we don't do it on serums. Okay, this is obviously something you're talking about, a late syphilis identification. Pardon me. Now, interpreting the Western blot, I know you've seen pictures like this before. This is showing you, we want the CDC here. This was a study that was done, what the study was suggesting versus what the CDC was suggesting. Well, this study is lovely, and you can see that they have less bands that they have to, or different bands that they have to be finding. The CDC has spoken, okay? So the CDC is telling us that these are the bands that they're looking for. And for IgG, we need to see reactive 5 of these 10 bands where the gray box is. So and the bands are just separated by kilodaltons. So we're looking at 18, 23 to 25, 28, 30, and then drop down 39, 41, 45, 58, 66, and then 93. 5 of those minimum have to be positive to consider the IgG positive. Okay. Then look separately at the IgM. There are 3 bands tested for in the IgM. And this is why we generally do IgG and IgM together. But there are 3 bands tested for, and 2 of the 3 need to be positive. That's 23 to 25, 39, and 41 have to be positive for IgM. So is it possible that your IgG is that your IgM is positive and not your IgG? It's entirely possible. Okay, and what that will probably be resulted as is equivocal. If you get 2 out of 3, it might be positive, early positive, but you would be recommended and bring that patient back and get another blood in a couple more weeks, okay, a few more weeks, so that we can definitely verify that IgG. Then this is just a little chart which I thought was useful in differentiating the clinical symptoms that will be associated with the different stages of Lyme's disease. And you can see it's not really as different from stage to stage as it is in something like syphilis, right? You have a rash in the first stage, you have a rash, you have multiple rashes in the second stage. You have joint pain in the first stage, you have joint pain in all the other stages, okay? The neurologic, you can see the different stages here. Initially, it's probably just a headache, which you would associate with flu-like symptoms. But Bell's palsy, eye sensitivity, cranial neuritis, all these things, inflammation, any kind of pain, those are associated with secondary stages, but they get much worse as you go through, okay? Cardiac secondary stage, the AV block is the worst case scenario, and the problem with this one is if you really do develop an AV block, you can have a heart attack and die, never then progressing to chronic stage. This is luckily not as common, and so we don't necessarily have as many. You saw it was only 1%, so much less common, which is good. However, these parts, the flu-like symptoms, the lymphadenopathy, all of these things, very common. So the musculoskeletal and the lymphatic, constitutional lymphatic, those very, very common to any case of Lyme's disease. This is just, again, a point, I want to bring up this point with PCR. Here's our trouble with PCR, and the trouble is gene homology. These are sequences of a 259 base pair amplicon of urine specimens that if you look at the upper DNA sequence here, JS1 here, this is a portion of Borrelia-Burgdorferi, the ribosomal RNA gene, okay? Then if we look at where to go here, the wait, let me go down here. Okay, so then you have other sequences, and the big thing that hopefully that you're noticing, sorry, is that you have some gene homology. What we're looking for here is finding those sequences that will be unique and will not have cross-reactivity with other species. Okay, and so they seem to, this particular study was demonstrating that they thought that JS1, FS1, and JS2 were useful in identifying the 23S ribosomal RNA gene for Borrelia. Okay, and these are used, JS1, FS1, and JS2 are the primer set used for PCR by this particular kit that they're promoting in this study. Treatment, last bit, treatment. Well, for each one, the treatment is similar and not so similar. It really depends on which stage of the disease you're in. Obviously the best treatment would be obviously don't get it, right? So we don't have, however, vaccines for these guys yet. Part of the major problem with syphilis is an antibody response against it doesn't protect you against future infection because there's so few trumps. So vaccines really they haven't really even thought about them. With Lyme disease, it's different. We have run vaccines against these. Unfortunately, when you study Lyme, you generally study it in animal models. Well, it doesn't act the same in animal models as it does in human models. And so the vaccine that was produced against Lyme had some unfortunate side effects, the biggest one being that it caused pretty significant autoimmune disease. There is a vaccine for dogs in Lyme, which is fine, but it doesn't correlate to humans. Okay, protects your puppy though. One of the best ways to prevent Lyme disease in your house is to protect your animals and make sure that they don't get ticks. So not just killing ticks that are attached to your animal, but to repel ticks. Constant repelling of the ticks is important. If we can repel those ticks, then we can make sure that we keep them from entering our house. Okay, and then second from that is wearing protective clothing when you go into the woods. Ticks can get pretty much anywhere because they're so flat, but if you wear the right clothing, you'll be hopefully protected. Okay, so for syphilis, where am I? I just lost my space. Okay. For syphilis, our first stage, our first level treatment would be penicillin, an intramuscular injection. If the patient is allergic, we can use doxycycline. And if they don't have any muscle, which believe it or not does happen, because HIV patients get syphilis, HIV patients also experience wasting syndrome where they lose muscle. Intramuscular injection really becomes a problem for these patients. So they have other drugs that they can use more IV. Azithromycin has been used. Unfortunately, resistance has been reported with that. So what that tells me is that the dosage and the length of time for using that has not been followed. Penicillin literally is one giant intramuscular injection, very painful. The penicillin, I get this from my mom. The penicillin formula that they use is very thick, like molasses, and they take a pretty good dose of it that's in a bolus injection, usually into your butt. Well, if you don't have a butt, then we can't do that, but it's very painful for them. But the choice of this or temporary pain in your butt or neurosyphilis, then we'll take the pain in our butt. Now that's if you have primary, secondary, or latent syphilis. Once you move to neurosyphilis, they use different formulations of the penicillin because it has to be able to get into the cranial cavity, into the central nervous system. And so they used, now a pharmacist to be able to tell you the difference between these, I don't think it's that important to you, except to note that it's not just an intramuscular injection. It's a different situation altogether. We've got to get that drug through that blood-brain barrier. And same thing with congenital syphilis. We do want to use a separate formulation of the penicillin that's able to get into that central nervous system to protect the baby. For Lyme's disease, there has been some controversy over the treatment of Lyme's disease because most people don't want to wait 6 weeks to find out if they need to start treatment. So there are physicians who have done automatic treatment for every tick bite. That is just, you're not supposed to do that, okay? Just because you have a tick bite doesn't mean you have Lyme's disease. In particular, depending on where you live, okay? However, when you start to see clinical symptoms, starting with the rash, then that can be changed. You can start thinking about treatment. There are several oral antibiotics that can be used: penicillins, tetracyclines, macrolides. For most adults, you're going to start with doxycycline, okay? Although cefuroxime and amoxicillin have also been used. The macrolides are the least effective against it, so it's not suggested. And this would be for when you see that rash, or if you're seeing like multiple rashes that's disseminated already, doxycycline, minimum of a month, okay? For young children, if it's early or disseminated, instead of doxy, they'll give them, because it's a little bit harsh on their baby livers, they give them amoxicillin or cefuroxime, okay? And that will depend on the severity of the outbreak, whether they'll go 6 or 8 weeks. Once the patient has neuroborreliosis, so what are the signs? They have Bell's palsy, they have major neurological symptoms: headache, pain, neck pain, back pain. These things will require treatment for neuroborreliosis because you need to be able to get that drug into the central nervous system, hence IV therapy. So that it does require IV therapy once you get to that stage. Patients don't necessarily equally respond to treatment equally. So it will require some level of skill for the physician to be able to determine which treatment will work the best for the patient, and it will require close watching. There is no easy way through either one of these. There's no easy way. These are difficult diseases to treat, and you want to make sure that they're gone because we don't want them to continue on to a latent or to a tertiary stage.